Hello, I am Dr. N.S. Mani, and this session is the postgraduate medical entrance test practice session, session number 4 in surgery. Please visit the channel youtube.com/acpgmed, and if you got Facebook account, please visit the Facebook account facebook.com/acpgmed. And there are lots of videos uploaded in this channel. More than 70 have been already uploaded. The 18th question in the series and the first in this session is: the victim of blunt abdominal trauma requires a partial hepatectomy. He is rapidly transfused with 8 units of appropriately cross-matched packed red blood cells from the blood bank. He is noted in the recovery room to be bleeding from the intravenous puncture sites and the surgical incision. His coagulopathy is likely be due to thrombocytopenia and deficiencies of which following factors: 2 only, 2 and 7, 5 and 8, 9 and 10, 11 and 12. The answer is C. When large amount of banked blood are transfused, recipient becomes deficient in factor 5 and 8, which are called labile factors, which are also labile factors, and an acquired coagulopathy ensues. Since banked blood is also deficient in platelets, thrombocytopenia may also develop. You can see in this picture the dense cutaneous petechiae on the foot and ankle, and there are no petechiae on the sole of his foot, a site at which the vessels are protected by the strong subcutaneous tissue. And in this picture you can see the occasional petechiae on the patient's face and large bullous hemorrhage on the buccal mucosa, which are related to the lack of vessel protection by the submucosal tissue. Similar petechiae and hemorrhagic bullae can be seen in patients with thrombocytopenia of any cause. Petechiae are small capillary hemorrhages. They characteristically develop in crops in areas of increased venous pressure, such as the dependent parts of the body. As a result, they are most dense on the feet and ankles, and fewer are present on the legs. Petechiae are not found on the sole of the foot, where the vessels are protected by the strong subcutaneous tissue. They are asymptomatic and not palpable, and should be distinguished from small telangiectasias, angiomas, and vasculitic purpura. The 19th question: following ciliiotomy, normal bowel motility can ordinarily be presumed to have returned. Which are the following 5 options? Stomach 24 hours, small bowel 24 hours, colon first oral intake. Stomach 24 hours, small bowel 4 hours, colon in 3 days. Stomach 3 days, small bowel 3 days, colon 3 days. Stomach 24 hours, small bowel 24 hours, and colon 24 hours. Stomach 4 hours, small bowel immediately, and colon 24 hours. So the important thing is stomach, small bowel, and colon, whether it is immediate 4 hours or 24 hours or third day. Which permutation combination is right? That is the B. The misconception that the entire bowel does not function in the early postoperative period is still widely held. Intestinal motility and absorption studies have clarified the patterns by which bowel activity resumes. The stomach remains uncoordinated in its muscular activity and does not empty efficiently for about 24 hours after abdominal procedures. The small bowel functions normally within hours of surgery and is able to accept nutrients promptly, either by nasoduodenal or percutaneous jejunal feeding catheters, or after 24 hours by gastric emptying. The colon is stimulated in large measure by the gastrocolic reflex, but ordinarily is relatively inactive for 3 to 4 days. Ileus refers to obstipation and intolerance of oral intake resulting from a non-mechanical insult that disrupts the normal coordinated propulsive motor activity of the gastrointestinal tract. It is derived from the word ileus, Greek word, which means twisting. There is general consensus among surgeons that some degree of postoperative ileus is a normal, obligatory, and physiological response to non-abdominal and abdominal surgery. Average postoperative gut dysmotility, that is normal physiologic POI, is widely reported as lasting 0 to 24 hours in the small intestine, 24 to 48 hours in the stomach, and 48 to 70 hours in the colon. Neurological control of the GI motility also has to be understood. Control of GI function and motor activity is complex based upon the interactions of the various neural networks and neurohumoral peptides. Neurons located in the gut wall comprise the intrinsic neural network, which is called the enteric neurus system, ENS. The extrinsic network consists of visceral sensory afferents in the vagus, splanchnic and pelvic nerves, and the visceral motor efferents of the autonomic nervous system, ANS. These extrinsic neurons synapse with the ENS and connect it to the CNS, central nervous system. So there is ENS, ANS and CNS. The schematic of gastrointestinal greater nervous system. The CNS, visceral efferent system, ANS, the ENS, sensory neurons and motor neurons, and they go to the intestinal smooth muscle. The visceral sensory afferent goes to the CNS. CNS means central nervous system, ENS means centric nervous system, ANS means autonomic nervous system. In general, vagal afferents are thought to be important in the coordinated integration of motility, secretion and absorption, while spinal afferents are thought to be responsible for the transmission of noxious stimuli and inflammation. Visceral motor efferent outflow consists of the sympathetic, thoracolumbar and parasympathetic craniosacral arms of the ANS. Sympathetic activity is generally inhibitory to smooth muscle activity, while parasympathetic input can be excitatory or inhibitory. The ENS also has the basic circuitry necessary to run independently through the local circuits that rely on signals from intrinsic sensory neurons and neurohumoral peptides such as substance P, vasoactive intestinal peptide VIP and nitric oxide NO, which can act either in a paracrine or endocrine fashion. Pathogenesis of postoperative ileus through three common pathways: inhibitory neural reflexes, inflammation and neurohumoral peptides. Inhibitory neural reflexes. Inhibitory neural reflexes are thought to act locally through noxious spinal afferent signals that increase inhibitory sympathetic activity in the GI tract. The clinical importance of this mechanism is that blockade of spinal afferents with epidural local anesthetics or with the topical capsaicin can improve POI. Inflammation. POI appears to result from an inflammatory response to intestinal manipulation and trauma. Local macrophages activated by the intestinal manipulation produce an inflammatory response that results in muscle dysfunction. The degree of intestinal manipulation of both the small and large intestine is directly related to both the amount of intestinal dysmotility and the degree of neutrophil infiltration into the intestinal muscularis. Moreover, this effect is not necessarily limited to the manipulated segment, as there appears to be an inflammatory field effect affecting the entire GI tract. Intestinal manipulation appears to increase the cyclooxygenase 2 COX-2 expression and elevate prostaglandin levels, which in turn decrease jejunal contractility. This effect is blocked in COX-2 deficient mice and by the administration of selective COX-2 inhibitors. Neurohumoral peptides, nitric oxide, vasoactive intestinal polypeptide, possibly substance P, are thought to act as inhibitory neurotransmitters in the gut, which slow gut motility. Hope that the session was useful to you. Next session will be uploaded. Goodbye. Please visit www.youtube.com/acpgmat. Thank you. You can mail your doubts to acpgmat@gmail.com or drnsmanimd, drnsmanimd@gmail.com. Thank you.